Laryngeal cancer preservation does not end when radiation ends. For speech-language pathologists, the first year after treatment is where the outcomes are protected or lost. I'm Lauren Meffen, speech-language pathologist and certified lymphedema therapist. Today, I want to walk you through how to think about laryngeal care and cancer treatment from 1 to 12 months following radiotherapy. We are going to use a structured, time-based approach. At 1 to 2 months post-radiotherapy, this is typically the first reevaluation window. The focus here is a baseline recovery, not pushing the function too fast. At this stage, I am assessing swallowing function, diet status, patient-reported outcomes, using scales such as EAT-10s, MDADIs, or the MASSC. I'm also assessing neck circumference measurements with photos to track external swelling. We assess internal edema utilizing the revised Patterson scale, and importantly, respiratory and upper airway collaboration with the ear, nose, and throat physician. This is also the phase where I strongly discourage NPO, nothing by mouth, unless it is explicitly ordered by the surgeon. We want to reinforce the swallowing. At this stage now in recovery, laryngeal cancer is typically a lower risk for trismus, but I still assess maximal interincisional opening and track this with my patients. Treatment often includes respiratory muscle strength training, individualized dysphagia exercise, cervical range of motion, and physical therapy consultations. We are monitoring our patients, not overwhelming them. Now 3 to 6 months following radiotherapy, this window is considered the intensive rehabilitation window. We establish new functional baselines for voice, swallow, and airway clearance. At this stage, I am assessing external and internal lymphedema, soft tissue staging, fibrosis may start to sneak in, jaw opening, and the ongoing 3-finger rule check. Any feeding tubes that are in place, the goal is to progress them off of the feeding tube. In the 3 to 6 months following treatment, here becomes very active. Manual lymphatic drainage combines myofascial techniques. We plan our compression garments and our skincare and exercises. Our exercises devices include expiratory muscle strength trainers, tongue trainers, and potentially a voice evaluation utilizing a stroboscopy exam with acoustic analysis and measures. The goal for our patient is independence. Now 7 to 12 months following treatment, we transition from this intensive rehabilitation to a structured home program. This doesn't mean discharge without support. At this stage, we are educating our patients on the expected outcomes of their lymphedema, their fibrosis progression, any jaw opening changes, diet consistency, endurance, internal measurements of edema, and I am still troubleshooting anything that limits my patient's function. Interventions during this time period can include directional manual lymphatic drainage, ongoing compression use, effortful swallows, suprahyoid strengthening, potential pump candidacy when appropriate, and this phase is about long-term sustainability. Throughout all phases of laryngeal cancer survivorship, we require a multidisciplinary team. Our ear, nose, and throat physician, oncologist, speech pathologist, physical therapist, nutrition, mental health, primary care, radiation oncologist, and dental is all involved. No single provider carries this patient alone. Laryngeal cancer preservation is successful when function is protected over time. A structured, time-based plan helps clinicians anticipate problems before they become permanent. The checklist is part of a larger survivorship framework that I use in our head and neck rehabilitation. You can find the full resources linked below along with additional clinical tools.